You, Dr. Thomsen, were looking into the optimum timing of endocrine therapy, and that's optimum timing not only about when to give it, but even whether to give it, if I'm not mistaken, based on this study you're now reporting. What were you doing here?
That's correct. In the 90s, there were reports that compared bicalutamide 150 monotherapy to castration, and they found that in non-metastatic patients with locally advanced prostate cancer, the survival was comparable between these two strategies. So there was an interest at the time, because of a more favorable toxicity profile of bicalutamide, to investigate when and where to initiate the time anti-androgens, in this case bicalutamide 150. So we enrolled 1,280 men with hormone-naïve non-metastatic prostate cancer and randomized on a one-to-one basis between bicalutamide 150 and placebo.
So what were you looking for specifically?
The co-primary endpoints were progression-free survival and overall survival, and we have in this time only updated the survival status. The progression-free survival has been reported several times, and the last independent with 7 years follow-up, there was significantly favorable according to randomization to bicalutamide.
Now you've divided it into two groups, 600 actually getting the bicalutamide. What did you find?
Well, overall we found this was a negative study. There was no benefit on survival on bicalutamide immediate therapy. However, when we stratified according to disease stage, we actually saw that in localized patients there was no effect. Survival favored randomization to placebo, whereas in patients with local advanced prostate cancer, there seemed to be, as this is a post-hoc analysis, there seemed to be a survival benefit of immediate anti-androgens.
What are the messages coming out of this? Because it sounds as if you could not use this hormone therapy in some patients.
That's correct. If you have a patient who do not want to or is unfit for curative therapies, and he has localized disease, you should not commence immediate ADT, and in this case androgen deprivation, in this case anti-androgens. However, if the patient has locally advanced prostate cancer and the same setting, he would be an ideal candidate for immediate anti-androgens.
Could you run me through the figures? You've got an advantage in survival.
We do, yes. With a median follow-up of 14.6 years, there is a survival difference of 1.8 years for bicalutamide in locally advanced disease compared to placebo.
So is this now a clear-cut clinical finding that you can apply?
Well, it is, but sadly the time has changed. At the time of the initiation of the study, watchful waiting was an approach used in Scandinavia, and today these patients would have undergone curative therapies. So you would have to pick your patients correctly for this time of therapy.
You'd need to pick them early on in their disease.
You need to find them at the correct time, and the patient who do not or cannot undergo curative therapies. You do not need to find the localized stages, but the men with locally advanced prostate cancer who do not feel or do not want to undergo curative therapy, they could be an optimal candidate for anti-androgens.
Right, you've spelt out some of the clinical message. How would you summarize what's coming out of this for cancer doctors?
Bicalutamide 150 monotherapy does not add any survival advantage compared to placebo in hormone-naïve non-metastatic prostate cancer patients. Post-hoc analysis indicate that locally advanced prostate cancer have an increased survival compared to placebo.
What would you like to see by the way of practice changes coming out of these very fascinating findings from nearly 15 years of follow-up?
Hopefully you would consider adding or consider starting bicalutamide instead of castration-based therapies. The toxicity profile is more favorable compared to castration, and we have now almost 15 years follow-up showing that in the right patient there is a survival advantage.
In which patients can you withhold bicalutamide therapy then?
Locally advanced prostate cancer do not have any benefit of bicalutamide.